Good afternoon, everyone. Welcome to my progress report presentation. My PhD topic is about the oral complications of type 2 diabetes mellitus. My name is Kata Haba. I'm a third-year prosthodontist resident at the Department of Prosthodontics. I have two supervisors, Daniel Vég and Dóra Haluska. My SMS is Cindy. My statistician is Gergely Agócs. My vision is to improve the life quality of patients with diabetes. My mission is to detect all the potential oral complications and target them. I have two specific goals ongoing. I started both of them in 2023. I'd like to achieve them both with systematic review and meta-analysis. Let's jump to my first one. This is about the correlation between salivary and blood glucose levels. My co-investigator for this project was Patrick Reuter. Little background for it: diabetes mellitus is a chronic metabolic disorder that affects many organs in the human body, including the oral cavity. And there are several million patients who have to endure the inconvenience, cost, and pain on a daily basis for measuring their glucose levels from blood samples. Therefore, our aim was to detect a potential new method for glucose level measuring from saliva samples in a less inconvenient way, if possible. A clinical question was, what is the relationship between salivary and blood glucose levels after fasting? And we chose the PERT framework for that. For our population was a general population. Our index test would be saliva test based on glucose oxidase method. A reference test was blood test, and the diagnosis of interest would be correlation. Our hypothesis was that the salivary level matches with blood glucose levels after fasting. And again, my clinical implication was to detect a new method for glucose level measuring if possible. I did my search with the search key below on the 22nd of November in 2023 in 4 databases, and I have quite a large number of articles included, and we went down to 25 articles eligible for full text from when I did my data extraction phase. I have all my outcomes and analysis done. I have mean differences with a 95% confidence interval, individual patient data where it was eligible, and correlation for diagnosis of interest. Let's see my first one. This is a scatter plot about correlation between salivary and blood glucose levels from mixed saliva samples. As you see, it has many dots, almost 1,000. These are individual patient data from 9 articles. We extracted them manually where it was available. The green range represents the normal glycemic range. The yellow one represents the impaired fasting glycemia, and the red one is for the diabetic range. As you see, we fitted a linear regression model for each data set for each articles, and we also added a mixed effects model for the whole data set, and based on the coefficient of determination, the R-square value with 0.05, it was a poor fit. So we went back to the literature to see if we could see a much higher correlation. And on my second figure, as you see, the saliva sample was isolated from parotid only, and it showed a much better correlation, but still not what we were hoping for. But we could only extract around 100 IPDs from the article, so it's only for a show. My third figure is a forest plot for salivary glucose levels, mean differences between the two groups. Study group is for the patients with diabetes, and the control group is for non-diabetic patients. As you see, it has quite a large number of patients enrolled, but we have a high heterogeneity as well. We could find an answer for that based on the description in the articles. They did not unify the sample storaging and the volume of the saliva samples that they took for their measurements. And my fourth figure is forest plot for blood glucose levels. It's again mean differences, and as you see, it's statistically significant. The strength of our study is that all the articles have well-described methods for sample taking for both tests, but as I mentioned, not for sample storaging and proceeding with it. And they enrolled a big number of patients, and we could extract a high number of IPDs where it was eligible. For limitations, we have to mention that only a few articles included individual patient data, and some of the articles do not mention important health data that could potentially influence the measurements. And as I said, the sample storage method aren't unified. For conclusion, we could say that blood glucose measurement is still irreplaceable based on results, and we do not recommend to use it instead of blood glucose level measurement. And we implicate for research that we have to target all the potential influencing factors and develop a standardized methodology for saliva sampling and taking and storaging it both for a potential using it as a diagnostic tool. Here is my first project progress. As you see, I'm already done with the manuscript writing phase. I sent it to internal review last week, and I am waiting for my reviews until tomorrow, and I expected to submit it by the end of January. My target journal will be Diabetes Care. Let's see my second project, which is about evaluating oral hygiene and periodontal complications among patients with hyperglycemia. It would also be a systematic review and meta-analysis. My co-investigator for this project is changed. It's Wuchu Banza. Little background, investigating the link between periodontal health and hemoglobin A1C levels is crucial for enhancing diabetes management, as one part, periodontal disease can impact and worsen systemic health by potentially worsening the diabetes control, and controversially elevated hemoglobin A1C might aggravate periodontal conditions. Therefore, our aim with this study is to show the need for regular oral checkups with hyperglycemic patients to integrate oral health into managing their diabetic status. A clinical question would be, how does the abnormal hemoglobin A1C levels affect periodontal outcomes? We choose the PER4 framework for that. For population would be also a general population with hyper and normal glycemic patients. The prognostic factor would be the different levels of hemoglobin A1C, and the outcomes would be the periodontitis values like pocket depth, clinical attachment loss, and bleeding on probing. And we hypothesized that the stage of periodontitis is more severe in patients with higher hemoglobin A1C level. And again, my clinical implication is to emphasize the importance of frequent dental checkups among patients with hyperglycemia. We are currently in the photo selection phase. I was recommended in September to submit my Prospero first after we did some preliminary data extractions. So I did it mid-November. We did the duplicate removal and title abstract selection with my selection partner, and we are currently in the photo selection phase. We have quite a lot of number for photo selection, so we are a little slow, but we are eager to finish it by the end of February. For summary, I have 2 projects ongoing. I plan to submit my first one in 2 weeks, and the second one by the end of the year. And I'd like to thank you for your attention by a quote from Louisa May Alcott from Little Women: "No good can come from doing nothing." Thank you very much.
I have a question regarding your second topic. Do you plan to investigate subgroups in your second project?
Yeah, thank you for your question. Yes, I plan. As you see, we could make some subgroups based on the type of diabetes the patient have, based on the treatment of the diabetes, what the patient has, ages, smoking habit, sex, and etc. Yeah, we plan.
I just want to be sure that in the forest plot you found, in the first study you found some significant differences between diabetic patient and non-diabetic patient in the sugar level. In general, it's like a mean, so it's not a correlation but a mean. So I'm just wondering that, is this sugar level in the saliva has any effect on caries? So it has a relevant level or it doesn't care about it? Because that would be another interesting result.
Would be, it sure has. Actually, I'm doing a basic research that investigates quite the same, and it's a little bit together with the perfusion that the tooth get from the pulp and from saliva, and how it affects the collagen in the dentinal phase. And yeah, it can. The significance is not clear yet, but I'd like to investigate it, yes.
So even if there is no correlation and you cannot use it as a test, but there has some other clinical levels.
Salivary glucose is actually not transported with an easy diffusion into saliva. It is transported by a sodium glucose cotransporter, and if the blood glucose is higher, the salivary glucose transporter is higher as the gene expression enhances, and the salivary glucose level is higher, but we can't find how they correlate with each other. So it's for sure not a linear, or not just a linear correlation. We have to investigate other factors that could influence these measurements.
For a follow-up on the previous question regarding the subgrouping for your second study. So you said you might consider, or you are considering subgrouping for the types of diabetes. Do you think there might be any dependence on, or let's say, what type of periodontitis this is, so that the different levels of HB1AC could influence different types of periodontitis more severely? And in this case, would you consider subgrouping for this as well?
Yeah, I would, because it's a two-way relationship between diabetes and periodontitis, so sure, we would like to if we can. Yeah, so if it's a more severe periodontitis, we'd like to see if the hemoglobin A1C levels is higher, because it could indicate us that it's a well-treated diabetes or a non-well-treated diabetes. So yes, for sure.
You said that in the first study, you were looking at when you were trying to investigate it deeper and what type of saliva it was, and you looked at parotid saliva. Did you also maybe, what other types of saliva could it be? Was it stimulated or unstimulated saliva? Did you do an investigation in this?
By our measurements, it was non-stimulated, because we wanted to make sure that it's only the basic that we have at home. So we'd like to develop, if possible, a home care kit for patients who don't have to stimulate their salivary flow rate. So it was unstimulated.
You said that you would like to do a subgroup analysis. Would you like to consider gestational diabetes in that regard, or that would be too complex or unfeasible?
I have to check it with my supervisors. I'm not sure if we'd like to investigate, because it's much more difficult than type 1 and type 2 diabetes.
Also, regarding your very first study in figure 3, we could see quite a big difference between the study of Wang and the study of Niranda, which showed -5 and +20 in the mean difference. Do you know what was the main differences between those two? Why there was such a difference?
Well, we didn't have any answer for that. We were investigating it, but where it was an outlier, we found that maybe it has some reporting bias as well.
In this case, did you consider maybe a leave one out study as well?
Yes, we did, but by the end of our meeting, we found that maybe we could just leave it there and give it an explanation that it is not a well-described reporting in the article.
You might consider having both and then having one in the supplementary for completion. And if you are uncertain with one, then maybe to present it without this as well.
Okay, thank you.
Could be just considered.
Okay.